Our next speaker would be Dr. Manpreet Kaur, and she'll be speaking on challenging situations in smile. And I think it's an important topic because we all want to end up smiling after spending a lot of money and not having an unhappy patient.
So, though this photo looks like a smile, the patient was definitely not smiling in this one. So, I'll be covering the challenging situations in smile. I have no financial disclosures. So, as we all know, LASIK we follow the dictum of see one, do one, and teach one. For smile, it does not really hold true. There is a significant learning curve with the majority of complications occurring in the initial few cases. Lenticule dissection and extraction being the most challenging step. This is our documentation of the learning curve. What we observed was that it decreases from 16% in the initial few cases to only 2% of complications in the next 50 cases. So the learning curve, though steep, does decrease over time. So suction loss, black spots, opaque bubble layer, cap lenticular adhesion, retained lenticule, cap and side cut tears may be observed. Suction loss is basically due to the inherent soft docking in which the cornea is accurvated rather than applanated, and it's a low pressure suction cone with only 35 millimeter mercury of pressure. So the incidence of suction loss ranges from 0.8 to 4.4% and can be as high as 11% for novice surgeons, further compounded by an uncooperative patient, deep set eyes et al. So now we have algorithms on how to manage suction loss based on the stage at which the suction loss occurs. First, you have to identify the underlying cause and the stage. So if it occurs at less than 10% of the lenticule cut, you just redock and restart the procedure. The problem is when it occurs at more than 10% of the lenticule cut, then you have to abandon the procedure and convert to a surface ablation or LASIK at same sitting or later date. Lenticule side cut, or cap side cut. Now we have the rescue mode in the machine itself. You can redock and restart from the point at which suction loss occurred by just decreasing changing the parameters slightly, decrease the lenticule diameter and the cap diameter respectively. Then coming to the main complication during lenticule dissection and extraction, difficult lenticule dissection and cap lenticular adhesion is the major issue. Conventionally, we dissect the anterior plane first, then the posterior plane. Novice surgeons, of course, may have difficulty in identifying the posterior plane as well, especially in thin lenticules. If you dissect the posterior plane first, you end up with a cap lenticular adhesion in which since there is no posterior stromal support anymore, the lenticule is stuck to the overlying cap. Going anterior and trying to dissect it from the cap does become difficult, and you can have a host of complications including retained lenticule, delayed visual recovery, cap and side cut tears, posterior stromal damage, epithelial defect, and irregular astigmatism. So we have described the use of anterior segment OCT as a rescue tool during difficult lenticle extraction in smile, because what is the major issue is you don't really know are you in the wrong plane or not. So ASOCT helps to identify that here the posterior plane is well delineated. You can see the whitish hyperreflective line, and anterior plane is not that well delineated because it's not been dissected as of now. So the lenticule is stuck to the overlying cap. There is localized posterior stromal damage where we have been trying to forcefully find the posterior plane posterior to the original lenticule cut. And so then you just go in with the Sinski or reverse Sinski and nudge the lenticule from the overlying cap. You see a meniscus shaped gap over here, and that helps you to confirm that okay, the lenticule is stuck to the cap, and then you can go in with a dissector. The free dissection, initially we found it difficult, so we just sort of peeled it off from the overlying cap from both sides and then extracted it with a forceps. So this is one of my cases in which we had a cap lenticular adhesion. With experience, of course, we became more confident in handling it. So I'm just going in with the reverse side of the dissector and just peeling off the lenticule from the overlying cap, coming till the site of the cap side cut, and then once there is an anterior plane created, I'll just go in with the dissector anterior to this, and yeah. So the subsequent dissection is not very challenging once you know what you have done and what you are supposed to now how to handle it. And in fact, in this case, I could extract the lenticule without using a forceps, and the dissection was almost as smooth as a primary case in which you go anterior first and then posterior. So most important is identifying the issue and how to handle it. You have to identify the lenticule edge, that's most important. This is another case in which there was a increased opaque bubble layer and black spots. So there's a difficult adhesion. So we went in with the forceps and tried to extract the lenticule. However, it was not completely separated from the peripheral adhesions. Or what we had was a retained lenticule, a torn lenticule with retained lenticule fragments. So you should always, in challenging cases, examine your lenticule to see if you have left any piece. And once you have a retained fragment, it causes irregular astigmatism, blurred vision, and customized surface ablation may be planned at a later date, but this irregular astigmatism does become challenging to manage. Now, double concentric edge separation has been described by us to manage cap lenticular adhesion, in which once the lenticule is stuck to the overlying cap, you can go in with the same maneuver that I described from both edges and then separate the lenticule till the midline from both sides so that the side cut tear does not extend and you do not end up with cap tear. Otherwise, this peeling of the lenticule does lead to smile-shaped side cut incisions, as I showed in my first slide. Then we have described a stepwise management algorithm for difficult identification of the correct dissection plane in smile. So cap and side cut tears can be seen in 0.3 to 16.2% cases, and side cut extension and tears are much more common than they have been reported. Related to surgeon inexperience, the bulky instrument hub, we are so focused on the leading edge of the instrument that we forget that the hub entangles in the site of the cap side cut and can lead to tears and extensions. Excessive surgical manipulations, sudden patient movements, and small incision size also predisposes. So always start with a larger incision, a 4 mm maybe, and then go to 2 mm as your experience increases. So this is a cap side cut tear, and this of course is a side cut extension and tear. And so a bandage contact lens usually suffices. So patient selection and is of course important for the initial few cases. Go for thicker lenticules, moderate to high refractive error, rather than going for 1 to 2 diopters initially. Avoid deep set eyes and uncooperative patient. We have described meniscus sign to identify the lenticule edge in smile. So this is initially to help prevent a cap lenticular adhesion and a lenticule misdissection. So if you see this frilled edge and the instrument is above it, then that means you're in the anterior plane. If it's below that, it means you're in the posterior plane. Microscope integrated OCT has emerged as a useful tool. However, it is as of now not integrated in the smile machine, so it is a bit cumbersome to shift OTs. Just to sum up, the initial learning curve of smile, of course, is surgically challenging. During femtosecond laser application, you may have suction loss, black spots, opaque bubble layer. During lenticule dissection, you can have misdissection, cap and side cut tears, and retained lenticule. Prevention, of course, is better than cure. Complications are inevitable, and timely detection and management give both the patient and surgeon a reason to smile. These are our work, a book on smile as well as current concepts in refractive surgery. You can go through them. And I would like to acknowledge my mentor and guide, Professor Jeevan S. Dityal. Thank you for a patient hearing.
Excellent presentation, Dr. Manpreet. Any questions from the audience? Okay, just to add on, suppose you don't have you don't end up with this rolled lenticule. I think the trick is whenever you are separating the anterior lenticule, not to separate it fully. You leave the 3/4 of it.
During posterior, we leave the attached edges at the opposite edge and the 3 and 6.
Yeah, 3/4 of the anterior and the opposite. And whenever you are entering from the posterior, you just start separating from the opposite side. I think that is the trick.
No, anteriorly we dissect fully. While we are dissecting the posterior, we leave some adhesions so that the lenticule does not fold. And those remnant adhesions are released last when you're trying to extract.
What we are doing is exactly opposite. We are separating the anterior first, 3/4 only. We are leaving 1/4 of the section. Then while we are entering into the posterior plane, we are just starting to separate it from the opposite direction. Once it is done completely, then we sweep it like this, so that the rest of the 1/4 of the portion also comes out with there. So what this, I don't have to put the extra instrument inside the eyes. That is the forceps. So many of the time it is the one which is causing the extension.
True.
So the lenticule edge separate just comes out from the incision side, and you can easily pick it up. That is what we are doing. And I think smile is the way to go forward. Would you agree?
Yeah, of course.
And what about the biomechanics? But nowadays the people are saying that the biomechanics of the smile and the LASIK both are same initially, which was claimed that the smile is a better biomechanics. Your views on that?
Yeah, ectasia has been reported after smile as well, and we do not have our personal long-term data. As of now, in our cases, we have not observed any ectasia, but just clinically also, when you observe post-op cases of smile after LASIK, you can always see the interface and those fine striae. In smile, if you don't search for the cap side cut, you can't even say the patient has had a surgery. It's so clean after a point of
Yes,
time.
but many
Yeah.
of the times we do not have this wow factor in the smile. So what can we do to have the wow
I
factor?
think with experience that wow factor does come.
I think another thing is the ironing of the Bowman's membrane, which is the most important thing. Whenever you remove the lenticule, you just hydrate the wound and you do the Bowman membrane. Doesn't matter it is a spatula or a sponge, but it is must. And I think with the correct energy settings, you need to know your machines well.
Yeah, of course.
So the
That's
dissection should
imperative.
be smooth. And once
Mm.
you have done that well, I think we have this wow factor. Initially, we were troubling. Our energy settings were quite high. It was around
Yeah.
30, 31,
Hmm.
and now we are on 23,
Okay.
and it's working absolutely fantastic.